So today we're going to take a look at ventricular fibrillation. There are two types of ventricular fibrillation that we would like to focus on, and the first one is going to be a fine V fib, and the other one that I'll bring in here in a little bit is going to be a coarse V fib. While they're both V fib, they do play do have a role when it comes to cardiac arrests and shockable rhythms. We're not going to spend a lot of time in this section on that. Just realize that coarse V fib usually responds better to conversion. So right off the bat, we want to look at, is this a readable strip? And when we look here, we can identify that this is in fact a readable strip. While it looks like artifact, this is still a readable strip. So yes, it is a readable strip. P waves present or absent. I'm struggling to find any real wave. It looks like there might be a few things in here, but I can't find anything that is consistent. So therefore, I call it absent. Therefore, I have no P waves for QRS. I have no PR interval. It's not consistent. I can't tell that anything in there is regular, and I have no QRS for every P. Since I don't have a P wave or a flutter wave or anything like that, I have no ability to look for an atrial rate. When I look at this, there seems to be that there is not even a pattern to it. It's just kind of like all over the place. So if I take a look up here and see that, even if I take this clump here, it does not look like this clump in here, or come down here, nothing looks alike. There seems to be no pattern to it. So there is I can't tell whether or not there's a QRS. So therefore, I'm kind of stuck with all of these things, and I'm saying, it almost looks like an artifact. It almost, in some case, appears to be an unorganized mess. I know it's really medical for you, right? So it is really, there's nothing in here that tells me that this is really organized at all. And because what's happening inside the heart, okay, is that, again, if I were to draw the heart, by now you're probably getting used to the heart, that when I draw the heart, I know that I have an SA node that sits up here, and my internodal pathways. Then I have my AV junction, and then my bundle of His, and it comes down into my Purkinje fibers. What's happening is that there are various pacemaker sites. This whole area in here, the ventricles, are all quivering. So when they're quivering, that is giving me this. Okay, that's what we're picking up. We're picking up the fact that the entire heart is quivering. This is a fine V fib because everything appears to be very small, very, very fine line. Basically, is the easiest way to look at it. It's a fine line, and therefore, if it's a fine line, it equals a fine V fib. Now, as I said at the beginning of this, when you get into a fine V fib versus a coarse V fib converts easier. This is why there's usually a recommendation to perform CPR for as long as you possibly can on an unwitnessed arrest until you defibrillate, usually within 2 minutes. You're trying to get the pacemaker sites in the ventricles to become more coarse. You're trying to get them to change to a coarse rhythm so that when we defibrillate, we massively depolarize those, and now we can hopefully bring them back into a more organized rhythm. So let's take a look here at a coarse V fib to look at the differences between the two. I just pulled in another slide, so that's why there's no more drawings on here. But this, as you can tell, again, this is a V fib. This is a V fib, which we identified earlier. But this is more coarse. Okay, so this is a more coarse V fib. And when you get into this more coarse V fib, this is going to respond to defibrillations, to countershocks, more frequently and much better than we will find with a fine V fib. So again, doing bystander CPR for a couple minutes usually converts it from a fine V fib to a coarse V fib, which then responds better to defibrillation. The hallmark to any V fib is that there's no rhyme or reason. There's no organization to the rhythm itself. You really can't identify whether or not this is whether or not there's a QRS complex in here versus a P wave, so you can't see what's going on. Now, a lot of times people will take a look at these things and they will say, well, if you take a look at this, it almost looks like it spindles. So I'm not sure how you see the spindling here, but it's very easy to have somebody look at this and say, well, is this a torsade? And the answer to this is absolutely not. There's no organization. If you want to take a look at the way that there is an organization or a pattern to a torsade, you need to pull up that video. But for right now, this is something that truly the patient is not alive. They are in V Fib. They have no pulse, and they need to be defibrillated and have CPR performed. So, it really gets to a point of why would you argue, particularly when you're looking at something for a shockable rhythm. It's either shock it yes or shock it no. And the only rhythms that we shock are V Fib and pulseless V tach. So that kind of gives you that hint. This would be something that we would shock and therefore continue to do CPR. All right, I think that pretty much does it for a V Fib. Not a whole lot there. Very important rhythm to be able to recognize. Hopefully you learned something. See you soon.